Unit 5, The Nurse as a Member of Discipline of Nursing, Patient and Caregiver Teaching. Objectives for Unit 5. Identify the purpose of patient and caregiver education. Identify the principles of effective teaching. Describe the similarities and differences between teaching and learning. Differentiate between readiness to learn and the ability to learn. And identify the essential aspects of a teaching plan and the characteristics of an environment that promotes learning. You will also be able to delineate factors that positively and negatively impact teaching effectiveness. Describe what teaching methods to serve the learning needs of a diverse patient population, including cultural influences, low health literacy skills, and gerontological considerations. Discuss the implications of using the internet as a source of health information. Describe methods to evaluate learning, and to describe effective documentation of teaching and learning activities. So, what the heck is TeachBack?
TeachBack is a way to confirm what your patient understands of what you've explained. It's a great tool that will not only help reduce our readmissions and improve our patient's experience, it improves our patient's comprehension.
I just don't understand. I don't have time to do TeachBack, and furthermore, what would I get out of it? Plus, I feel like I would be quizzing my patients and putting them on the spot.
I know. I felt that way too when I first started hearing about TeachBack, but I started to find phrases that worked for me, and now it feels authentic. I could actually see it help my patients and found that it helps to reduce the calls I receive after I've left the room.
Hey, you two, what are you talking about?
We just had this meeting about TeachBack.
TeachBack? What's that?
TeachBack is really a best practice that enables us as providers to learn from the patient what they understood by asking them to repeat back what they heard us say.
Oh, sure. I do that with my patients. As a nurse, I think it's my job to make sure I explain things well, so I'll say, I know we covered a lot of information. Can you tell me what you heard? Or I'll ask them a question like, when you get home, how many times a day are you going to take your medication? And just make up questions to be sure they understand. If they go home and don't understand how or when to take their medications, they could end up back in the hospital, and who wants that?
So do you just use TeachBack at discharge?
It's very useful during discharge, but I also use TeachBack when I'm doing any kind of education, or for sure when I'm sharing a new diagnosis. I've also used it when I see patients in the clinic too. It helps to make sure they know what the plan and the next steps are from the visit.
Yeah, I use it during their visit after I have reviewed the plan of care and what's coming next.
That's interesting.
Morning, Kevin. Have you thought any more about that TeachBack we were talking about?
No, but even if I wanted to incorporate this, I feel funny. It feels forced.
Let's try. Come with me to Mrs. Smith's room. I'm going in to discuss her discharge instructions, and you can see how I try to incorporate TeachBack. Knock, knock. Hi, Mrs. Smith. It's Dr. Gray again. I have Dr. Campbell with me as well. Would it be okay if he joined us today?
Yes, that would be all right with me.
Great, thank you. Well, Mrs. Smith, you're doing much better now, so we're ready to send you home. But it's really important that you make an appointment to see your primary care doctor, Dr. Johnson, within the next 5 days. If your symptoms get worse between now and then, we want you to come back in right away so we can check you out. It's also really important that you take your medication as prescribed. 2 pills, 3 times a day with food. Mrs. Smith, I know we've covered a lot, and I want to be sure I explained everything to you clearly. Can you tell me what you're going to do when you get home? When will you go to see Dr. Johnson?
I'm going to contact my doctor if I'm not feeling better in the next 5 days.
I'm sorry, I must not have explained it all very clearly. What I actually want you to do is to call Dr. Johnson, your primary doctor, and make an appointment to see him, regardless of how you're feeling, within the next 5 days.
Oh, I see. You want me to call my doctor even if I'm not feeling bad. I should still plan to follow up with Dr. Johnson in the next 5 days.
Yeah, that's right, you've got it. Now let's see, what questions do you have for me?
I guess that made a difference. She actually didn't understand.
Yeah, sometimes it's the small details that can make a big difference in how the patient does after they've left the hospital. It's always best when we can clarify those details in person before they go home. A few moments of teach back in the moment can help ensure patients receive the right follow-up and can save time in the long run. What do you think about teach back now?
I think I want to give it a try. I'd hate for my patients to be missing key details in their care. I guess I don't really know what my patients are taking away from my explanations and instructions, and I won't find out unless I ask them.
The moment the patient enters the healthcare environment to the time of discharge or termination of the healthcare relationship, the ongoing goal is to assist the patient and their family to develop effective health behaviors. Hopefully, we will be able to encourage and inspire them in ways that cause them to alter any lifestyle patterns they have which predispose them to health risk. Health education can be a very influential factor that is directly related to positive healthcare outcomes. Teaching our patients is a major aspect of nursing practice. It is also an important nursing function that is independently performed. The American Hospital Association drafted a document called a Patient's Bill of Rights, which mandates patient education as a right of all patients. The State Nursing Practice Act includes teaching as a function of nursing, and that makes patient teaching both a legal and professional responsibility. The Joint Commission has included standards for patient and family education and declared that patient education helps patients better participate in their care and make informed health care decisions. So what does this all mean? It means that it is mandated for healthcare providers to perform a learning needs assessment that includes the patient's cultural and religious beliefs, emotional barriers, desire and motivation to learn, physical or cognitive limitations, and barriers to communication. Your book lists the general goals of patient teaching, and they include health promotion, prevention of disease, management of illness, and appropriate selection and use of treatment options. Teaching is something that must take place during your care of the patient. You are always responsible to teach the patient and their caregivers, and this is not a responsibility that can be delegated to the PCT or the LPN. The practice of nursing is very fluid. It can and does change rapidly. This means that the nurse can be faced with having to shift from a known set of responsibilities and functions that are comfortable and familiar to a new way of doing things. This can be very stressful. You will likely see this on the floor. Nurses who are asked to do things in a new way often have a great deal of difficulty accepting change. As a student nurse, you have the blessing of being very sheltered. You will work with one or two clients in level 2, and you will have the backup of both your clinical instructor and the floor nurse assigned to the clients you care for. You can ask as many questions as you want, and you get help with almost everything you do. As a graduate nurse, you have to ramp up your performance level to care for a full client assignment, and this can be overwhelming at times. However, graduate nurses are assigned a preceptor that is readily available resource. When an RN license arrives, you are truly on your own. It can be absolutely staggering. The pace of the unit can discourage you from taking your time to learn new tasks. As a new nurse, you can look around and suddenly realize that the way you always envisioned nursing is not exactly the way it really is. We refer to the realization as reality shock, and it can be very discouraging if you are not prepared to deal with it. At that point, it is to your advantage to look for a seasoned nurse who will be willing to nurture a baby nurse and serve as your mentor. The seasoned nurse will know how to work within the system for best results and can pass on tricks of the trade that will help you to get up to speed. 1. Need to know. Children are fond of asking why, and the traditional parental response is because I said so. That doesn't work so much with other adults. Patients need to know what they have to learn, why they have to learn it, and perhaps most importantly, what's it in it for them. 4. Motivation to learn. No matter how eager and ready the patient is, when you present something new, the ability to recall that information can be easily compromised by the time they got through the process of getting home and settling in. It is much better for them to be able to practice use of the knowledge right away. They also do better if they are given short-term goals that they can reach within a reasonable time period than if they are only given goals that take a long time to reach. Also, don't overteach. Sometimes we want to teach the patient everything, which becomes overwhelming and can really dampen their engagement. 5. Orientation to learning. It used to be that patients regarded doctors and nurses as infallible. They took in whatever was said and never questioned. Now, patients have a different mindset. They are very aware that there's nearly always more than one way to approach a problem or situation, and they want to be involved in selecting their own path. So it is important to offer them choices whenever possible. They must also understand how the information you are presenting relates to their situation in order for them to incorporate it into their lives. Be sure always that you are presenting information that has been tailored to their specific situation. 6. Self-concept. The one thing that many patients fear, especially the elderly patients, is a loss of independence and self-control. It crushes their self-esteem to have all the power in a situation in the hands of someone else. As I stated before, the medical relationship used to be one of the patient just doing whatever they were told. But that kind of approach makes the patient much more likely to become disengaged and distant. As your book states, patients do not learn when they are just treated like children and told what to do. Effective teaching also involves assessment of the client's readiness for change. Table 4.2 in your book outlines for you the stages of change. Change is not a linear process, but involves forward motion and slipping back. Correctly identifying the stage of the client's readiness allows the nurse to use support techniques that align with the client's current state. Teaching versus learning. Learning is the process of acquiring knowledge, attitudes, or skills. Teaching is defined as helping another person learn. It involves arranging conditions to promote learning and hopefully produce the desired behavioral change. Patient education involves a teaching-learning process that has to be an active one, meaning that the teacher and the learner have to actively engage in working together to reach the desired outcome or change in behavior. You cannot just walk in, talk, and walk out and expect that the patient has learned. Remember that teaching only facilitates learning. Ultimately, the learner is responsible for what and how much is learned. But patients definitely benefit from contact with a nurse who takes the time to teach. The teaching-learning process requires a dynamic interaction between the nurse and the patient. Teaching is a system of activities that are intended to produce learning. In the case of nurse-patient teaching, the learning we wish to produce is very specific. The teaching process and the nursing process have much in common. Nurses teach a variety of learners in a lot of different settings. Ideally, nurses teach not just patients, but their families and significant others in the hospital, primary care clinics, urgent care, the home, and in assisted living or long-term care facilities. The teaching may be to groups of people or to a single individual. Learning is motivated by the needs of the client, and clients have a variety of learning needs. A learning need is a desire or a requirement to know something that is personally unknown to the learner. Learning needs included new knowledge and information, or new skills, new behaviors, or a need to change old behaviors. Learning is a change in human capability that persists. It is represented by a change in behavior. Readiness to learn is the demonstration of behaviors or cues that reflect a learner's motivation to learn at a specific time. When you are teaching a child, you basically just need to get their attention and have something that they want or need. When teaching an adult, we need to identify what information the person values, because if they don't see the point in what we are trying to teach, or if that point doesn't really matter to them, we will not be successful. We as nurses are looking for what is called the teachable moment. The teachable moment occurs when the client and the content or the skills being taught match up with the tasks that needs to be accomplished. Readiness to learn depends on multiple factors, such as perceived need, attitude, and beliefs. It is based on culture, personal values, physical and emotional stress, and past experiences with learning. Culture is made up of values, ideals, and behaviors that are the traditions the patient upholds. Culture provides the framework for solving issues and concerns of daily living. Culture is a major variable that influences readiness to learn because it affects how people learn and what information can be learned. Sometimes, no matter what we say or do, no matter how valuable or important the information or behavior we are trying to teach is, the patient may not accept it because it conflicts with his or her cultural values. You will save yourself a lot of time and frustration if you do a cultural assessment on your patient instead of just forgoing ahead. You need to discover those cultural patterns and incorporate them into your teaching learning interaction in an appropriate manner. Personal values. A person's values include beliefs about behaviors that are desirable and undesirable. As a nurse, you need to find out what value the patient places on health and health care. When the nurse fails to do this, misunderstanding, lack of cooperation, and negative health outcomes are more likely to occur. Realize that the patient's values and behaviors can be either an asset or a deterrent to readiness to learn. Patients are unlikely to accept health education unless their values and beliefs about health and illness are respected. Physical readiness. Physical readiness is very important because until the patient is physically capable of learning, attempts at teaching and learning are likely to be unsuccessful and frustrating. If your patient is complaining of pain that is an 8 out of 10, it is that pain that will have their attention, not you. They will not be able to concentrate on learning. It is the same if the patient is short of breath. The effort of breathing will require all of their attention. Emotional readiness. If the person has not accepted the fact of their physical condition, they will not be motivated to learn. If the person does not accept the prescribed therapeutic regimen, either because they do not believe in it or because it conflicts with their lifestyle, it will be difficult, if not impossible, to get them to learn about it, no matter how much you try to teach. However, we cannot always wait for the person to become emotionally ready to learn, because it is possible that time will never arrive on its own. In some cases, you as the nurse will have to work to stimulate the patient's motivation. For instance, a patient who has entered the hospital for hip surgery, then is discovered to be a diabetic, may be so completely focused on the surgery that they pay little attention to their high blood sugar. But we cannot simply say they are not ready and not bother. We will still have to teach them about the health consequences of having uncontrolled blood glucose. And we will need to help them to achieve emotional readiness. So, how do we do that? We can promote emotional readiness by creating a warm, accepting, positive atmosphere and by establishing realistic learning goals. Teaching in small bites is helpful in these cases because the patient is able to achieve success and gain a feeling of accomplishment. Past experiences. Previous educational experience and life experiences influence a patient's approach to learning. If the patient has little or no formal education, they may not be able to understand the teaching materials you present to them. If they had difficulty learning in the past, they might be hesitant to try again. Or if this is a patient that needs teaching about a specific therapeutic diet, it will be very difficult for them to grasp if they lack understanding about basic normal nutrition. So these are all things that influence readiness to learn. There are also non-modifiable factors that influence ability to learn, such as age, economic factors, the client's support system, and developmental stage. Your book points out that every interaction with a patient and a caregiver is a potential teachable moment. More often than not, teaching will take place in a spontaneous moment when the opportunity presents itself. However, this is not appropriate for all things that you teach. If you need to teach a patient how to use the consistent carb diet, it is then time to develop a formal teaching plan. Your book talks about the elements of a teaching plan in your chapter. A teaching plan includes assessment of the patient's ability, need, and readiness to learn, and identification of problems that can be resolved through teaching. Once you have a defined problem, you can then develop goals. Unless the patient is completely unable to participate, goals should be developed in a joint effort with the patient. The teaching learning process is more effective when mutual goal setting takes place. Unless the patient values the learning objectives, it is unlikely that very much learning will ever take place. It is also vitally important for all learning goals to be realistic and appropriate for the patient and the situation. Once goals are developed, you flesh out all the teaching plan with teaching interventions. Finally, you will evaluate the effectiveness of all of your efforts. Special patient populations. When you are developing a teaching plan, teaching techniques should be tailored to the patient's ability to learn. This means that consideration should be made for special patient populations. Older adults, the mantra here is to slow down and give the older adult time to comprehend. When possible, give the older adult written materials to assist those with short-term memory loss. Due to visual changes that occur with aging, use large printed materials on no glare paper. To maximize hearing, face the patient. Be aware that some older adults use lip reading to enhance understanding. Visually impaired. Use large print materials without highlighting or visual cues, as color discrimination may be impaired. If the patient is blind, convert materials to Braille or auditory formats. Hearing impaired. Have the patient sit closer to the speaker. Make sure assistive devices are working properly. Use a sign language interpreter if available. Use written materials and visual aids. Developmental disability. Teach the patient's developmental stage rather than the chronological stage. Use simple and concrete examples. Demonstrate the material and have the patient do a return demonstration. Promoting learning. Learning is facilitated by minimizing factors that interfere with the learning process. An optimal learning environment facilitates learning by reducing distraction and providing physical and psychological comfort. There should be adequate lighting that is free from glare, a comfortable room temperature, and good ventilation. Most of you know what it is like to learn in a hot, stuffy room. It makes you drowsy and messes with your concentration. Noise can be a big distractor for the patient and interfere with listening and thinking. To facilitate learning in a hospital setting, nurses should choose a time when no visitors are present and interruptions are unlikely. In addition, the time selected for teaching should be suited for the needs of the individual person. Scheduling a teaching session at the time of day when a patient is fatigued, uncomfortable, or when visitors are present is not conducive to learning. However, if the family is to participate in providing care, the sessions should be scheduled when family members are present so that they can learn any necessary skills or techniques. Privacy is essential for some learning tasks. For example, if the client is learning to change a colostomy bag, the presence of others can be embarrassing and interfere with learning. But if the client is particularly anxious, having a support person present may give the client confidence. Negative factors. One of the battles professional nurses constantly fight is a lack of time. This can certainly be a barrier to effective teaching. The time that the patient is actually available and capable of participating can be sharply limited as well. Still, it is important to plan time for teaching. As your book points out, teaching can occur with every patient contact. There is a great value in this approach because it tends to break information into small bites that are easier for the patient to digest and hold. However, it is also important to plan time for formal teaching that helps the patient toward the ultimate goal, discharge with return to as much normal function as possible, and management of any processes in the body that deviate from the norm. When mapping out your day of patient care at the beginning of the shift, plan time for teaching, just as you plan time for patient treatments. And in level 2, it is an expectation that you will perform some sort of teaching with your patient during the clinical day. Another barrier could be called student insecurity. Many of you feel ill-equipped to teach when you go into your clinical sites. That is a beast you have to slay. In my experience, students prepare very well to perform patient teaching and normally do an excellent job. The worst part is not what you don't know, it's your fears. Fear will make you seem as if you don't know what you are saying. Sometimes students are afraid the patient will ask a question they do not know how to answer. What do you do if the patient asks something that you don't know how to answer? Think about that. Patient readiness can be another barrier. Sometimes the patient has a hard time accepting the diagnosis and therefore cannot move forward into teaching and self-care. Your book points out that it may be helpful to keep pointing the patient toward the realism of the situation and the preparation that must take place. VA medical treatment, surgical treatment, or even discharge. A real problem is how quickly patients are discharged. It is often difficult to implement a teaching plan when the patient's stay is very short. This is another very important reason that discharge planning and teaching must begin on the day of admission. Cultural influences. As was mentioned before, culture is an underlying note that can greatly influence the way the patient approaches learning, health practices, and behaviors. Your book has a cultural assessment tool that can be used to identify cultural influences. But bearing that, you can just ask the patient if they identify with a cultural group, and then ask them to describe their beliefs regarding health and illness. We are looking in particular for conflict between teaching and behaviors we are promoting and the value and beliefs the patient holds dear. We must also find out if the patient uses traditional healing methods of the culture. If that is the case, we have to evaluate the methods used in light of the treatment plan to make sure both can coexist safely. Your book also mentions that it is important to know who is in charge in the family. In some cultures, the patient does not make independent decisions, but defers to a family elder or spiritual leader. If that is the case, you will not be able to teach the patient if the treatment plan does not have approval of the authority figure. Nurses generally tend to rely on short conversations or lectures as the vehicle for patient teaching, but often that is not the most effective method for a patient that is compromised by their medical condition. There are many other approaches that can be used to teach patients. Group teaching. One method that is effective and rarely used is group teaching. Often the units regularly tend to have patients with the same diagnosis. Why not have those patients receive common information as a group? Group teaching requires individual evaluation, just as with any other teaching, to assure that the patient gained sufficient knowledge. But it is a good way to help patients feel that they are normal, and also it promotes moral support. And of course, it can be a time saver. One teaching for 4 patients is much more time efficient than teaching 4 patients separately. Demonstration and practice. If the patient needs to be taught a skill, demonstration and practice are very important. The nurse demonstrates the skill and then gives the patient lots of opportunities to practice. Be sure to teach the patient with the same type of equipment they will be using at home. Teaching aids. Teaching aids can also be used. Those include books, pamphlets, pictures, films, slides, audio tapes, models, programmed instruction, other visual aids like charts and computer-assisted learning modules. It is very important for the nurse to review the materials to be sure they meet the learning needs of the patient. Reinforcement and follow-up. Success in teaching relies on the patient having ample time to learn and for the nurse to provide reinforcement. Follow-up sessions are very important to not only cement the material in the patient's head, but also to help the patient gain confidence in his or her abilities. Follow-up also lets the nurse discover if there is a need for any additional teaching sessions. Motivational interviewing. Another technique is motivational interviewing, which is a communication technique designed to motivate the client towards change. Table 4.3 in your book gives a good overview of this technique. Your text defines literacy as the ability to use printed and written information to function in society. Health literacy is the ability of individuals to obtain and understand basic health information needed to make appropriate health decisions. This is a bigger problem than you might realize. More than 1/3 of adults in the US have limited literacy. Your text states that patients who have limited literacy have difficulty understanding and acting on health information, which leads to health illiteracy. This is so important that health literacy was identified as a target area in the Goals and Objectives for Healthy People 2020. It is not surprising that when a patient is health illiterate, it results in poor patient outcomes and higher health costs. An example would be when a patient is unable to read a prescription to know how many pills to take, or they may take the wrong number of pills. What is this word? Once. In English, it is once. In Spanish, it is 11, once. Something that simple can result in an adverse effect for the patient who is health illiterate. The client often has less information about health promotion or management of a disease process because they cannot read the educational materials. Embarrassment or discomfort with their difficulty also makes them less likely to seek preventative care. As a result, they are more likely to end up seeking care through the emergency department and are more likely to be admitted than people who have adequate health literacy. There are assessments to help with detecting health illiteracy in your patients. Your book mentions a 1-question screening test that can be used. There is also a 6-question test called the Newest Vital Sign Health Literacy Test. It is available in English and Spanish. It takes about 3 minutes to administer and tests not only reading but math skills. It uses an ice cream nutritional food table to determine health literacy. The nurse reads 6 questions for the client to answer while the client refers to the food label. 1 point is given for each correct answer. If the result indicates the patient has limited health literacy skills, the nurse then knows to use clear communication techniques and a variety of teaching approaches to increase the patient's understanding. Often, the patient with health illiteracy is not detected. Given that unfortunate truth, it is suggested that nurses practice universal precautions when communicating. That means that they should be using clear communication and plain language with all clients to create a foundation for clients to be able to understand and act on health information. The internet is now a part of the lives of many, if not most Americans, because it allows them to obtain information quickly. Healthcare has become so much a part of the internet that it has fostered the term e-health, which refers to availability of electronic health information, products and services using informational technologies. It includes online appointment access, electronic prescriptions, billing review, email access between the client and the healthcare provider, and online health information. E-health has changed the playing field because patients who access online health information are individuals who expect to be a partner in healthcare decisions, rather than allowing the healthcare provider to assume a parental role. Patients know they can quickly do an internet search and get information about their disease and treatments. What they don't know is how to differentiate between a reputable site and one that gives unreliable information. That is why it becomes the job of those who provide health care to help them make sense of what they find. Older adults are using the internet in increasing numbers, and they agree that the internet is a valuable tool for finding health information. There are more and more websites geared toward older adults, but the quality and reliability or readability of the sites is a concern. Age-related physical changes may add another level of difficulty to internet use for seniors. Older adults who have lower incomes and lower educational levels may not own a computer or have internet access. That creates a gap between the haves and the have-nots. Those who do not have access can be informed that they can access the internet at public libraries and learning centers. Fortunately, many hospitals have internet connections, which provides the ability for nurses to integrate technology into patient teaching. Evaluation is the final step in the learning process, and it is a measure of the degree to which the patient has achieved the learning goals. It determines how effectively the patient has responded to teaching. Evaluation is both an ongoing and a final process in which the patient, the nurse, and often the support person determine what has been learned. Following evaluation, the nurse may need to modify or repeat the teaching plan if the objectives have not been met or have been met only partially. Follow-up teaching may be needed. Behavior change does not always take place immediately after learning. Often individuals accept change intellectually first and then change their behavior only periodically. An example would be a patient that knows she needs to lose weight, but only diets and exercises on and off. If the new behavior is going to replace the old one, it must emerge gradually, otherwise the old behavior will prevail. The nurse can assist clients with behavior change by allowing for backsliding and providing encouragement to continue. In some cases, the patient will need further evaluation after discharge, which will result or require a home care. The process must also involve the patient's caregivers. Evaluation is not the final step in the teaching learning process, but it is the beginning of a new patient assessment. This supports the circular nature of the nursing process. Documentation of the teaching process is essential because it provides a legal record that the teaching took place and communicates the teaching to other healthcare providers or professionals who interact with the patient. If teaching is not documented legally, it did not occur. Good documentation is the tool that facilitates continuity of care. It is also important to document the responses of the patient and the support person to teaching activities. What did the client or support person say or do to indicate that learning occurred? Has the client demonstrated mastery of the skill or the acquisition of knowledge? The nurse records this in the client's chart as evidence of learning. The process may then begin again if needed with new goals and a new teaching plan. The following video is from the Patient Education Update Association, and it discusses common patient education interaction and also common educational misconceptions that occur when dealing with patient education.
Educators Update, a show where we talk about patient education and patient education topics in a clinical environment. My guest today, as always, is Fran London. Fran is a patient education specialist for Phoenix Children's Hospital, and she's also a noted author, most recently author of the book No Time to Teach, which was voted Book of the Year by the American Journal of Nursing in 2010. Hi, Fran.
Hi, Chuck.
How are you?
Great.
Good. Well, I understand the weather's been kind out in Phoenix. You've had a break in the heat.
We had some rain. Very welcomed.
That's good. We had a little bit in Texas, too, although my little town didn't get any, but all around us we did, so that helps the lakes, so that's really good. Well, as I was doing the show prep this week, I was kind of having trouble coming up with some ideas, and so what I did is what I probably should do every week, is I took your book and I thumbed through it and I stopped at a page and picked out a topic. And here's where I stopped. And you called the chapter How to Waste Time Teaching. Well, for purposes of our discussion today, I'm going to call it the 8 most common patient education mistakes. And we're going to go through these one at a time and get your feedback on these. You wrote them, so I know you have some thoughts about them. And I know you also live these every day in terms of not only your own process of dealing with patients, but also in the folks that you work with. And I've seen some of these too, so I think we'll have a good discussion. The very first one that you talk about is make assumptions. Why is that a mistake?
That's the biggest mistake that people often make. And it's mostly because it's a conversation stopper, it's a relationship stopper. The best example I have of that is when in a patient education situation and you start talking about birth control. And if you're not aware that the patient is gay, that might be a conversation stopper.
I would say so. Yeah, that's one of those things goes under awkward or irrelevant.
Exactly. And it really hurts the relationship.
Yeah, and how do you avoid making assumptions? What should they do?
Assessment.
There you
Ask
go.
those questions. Yeah.
Yeah, and we did a whole show on assessment. I don't remember the number of it right off the bat, but for those that are watching that want to know more about assessment, they can look at some of the previous shows that we've done. And if I recall correctly, assessment was one of the things that most people skip, but ultimately is the thing that saves the most time. Is that correct?
Exactly. That's why it ended up on this list again.
Okay, excellent. All right. Number 2, teach before you know who you are teaching.
Which also refers to assessment. And the problem there is you need to know what they know, what they believe, who they are, so that when you present whatever information you present it appropriate for them.
Sure, that makes sense to me. And, a real life example, my wife's been a type 2 diabetic, but she also takes insulin. And she was in the hospital for a shoulder surgery, and the nurse noticed that she was diabetic and started talking to her about her diabetes and care for this, that, and the other without asking her any questions. And my wife said, well, no, your information is not right. I've been to my endocrinologist. I've got this, I've got that, and this is what I'm supposed to do. And if she had just asked a question, all that time could have been saved. And, kind of after that, my wife just kind of wah. She didn't pay attention to her after that. So I think that's a pretty important one. Now, number 3, this is interesting because in the book you just list it, but there's no explanation. And item number 3 is talk. What do you mean by that one?
Well, there are lots of ways we waste time when we're with patients. And some of it is talking about stuff that's just irrelevant and has nothing to do with that issue at hand.
Yeah. And I would tell you that my wife is a champion at that. She can get a doctor or a nurse off task so easily by just saying, I love your earrings, or where'd you get that bracelet? And there you go. They spent 10 minutes and they've got 10 other patients to go see. And we never got to the topic at hand. So you got to watch out for my wife in that type of situation.
And most people, I think part of it is just wanting to build the relationship with the caregiver so that you really can feel like you can trust them.
Yeah. Number 4 is lecture. Now, one could look and say lecture and talk are the same, but I don't think so. What do you mean by lecture?
I've had so many doctors do that to me when I was a patient. Just they have some idea in their head that they want to get into your head, and they just lecture about it. Or if they have an opinion that they think you're not doing something right, they'll just give you a stern lecture.
I've got a great example for that. Back to my wife and her diabetes. We've been through quite a few endocrinologists over the years, and we went to one that he came highly recommended. And so we were excited to go see him, and we took all of her meds that she had and everything. And he started off great by asking a lot of questions and asking about her lifestyle and all this kind of stuff. And then took her big, we had the big Ziploc bag full of medicine. We decided to bring them rather than the list. And he was saying, well, no, you don't need this, you don't need that. This causes this problem. And I was enlightened. I thought this was great. And then he went into a 20-minute diatribe on the evils of Big Pharma.
Yes.
And I was stunned by that, and we went to see him 2 more times after that. And I told my wife, I said, I can't take this. Every time we go, we get a big lecture on the evils of big pharmacy companies, and it's just not appropriate or germane to what we are there for. So we found a different guy after that.
Yeah, I've gotten lectures about the health insurance companies.
Mm-hmm. Oh, yeah. Yeah, it's easy to get in those discussions. Item number 5, don't let the learner interrupt you. Now, I can see that's a horrible mistake, right? They have a question.
Yeah, well, I've seen that happen in lectures, certainly, and definitely within patient education situations.
Mm-hmm.
And the issue is really adult learning theory, is that adults don't learn the same way that children do. Children learn things that you think they need to know in order to grow up to function. Adults, on the other hand, are already functioning. They know how to get through life. They know how to solve problems. The times when they want to learn are usually when they have a problem that they're not solving on their own. So they're ready to learn something new. And if you don't let them ask questions when they have the questions, you're missing an opportunity to actually teach them something, because that's when they're ready to learn.
Yeah, absolutely. And I've often heard that referred to as a teachable moment.
Absolutely.
When the patient is in the willing and ready to learn mode, and that doesn't often happen sometimes, depending on why they're in the hospital. So yeah, when you let those teachable moments or learning opportunities go away, or don't pay attention to them, that's a learning opportunity that is totally wasted, and sometimes those are rare.
And that goes hand in hand with lecture. That if you're lecturing, then you're not going to stop to let them ask.
Yeah. Item number 6, listen in a hurry. What is that?
Sometimes we go into a patient's room and have an idea of what it is we want to talk about. And if you're always thinking about what the next thing you're going to say is, or where the next topic is going, you're hurrying getting through what it is you want to talk about. And then you're not really listening. When they ask a question or when they say something or make a response of some sort, you're not there. You're someplace else.
Yeah, and sometimes that's the fault of the system too, because there's so much pressure put on the nurse to do this and do that and document this and document that they're thinking ahead of really their next patient, knowing that I've got 10 more things to do before the end of my shift or whatever, and so got to hurry up and get through that.
But that's my point of this list, because if you do these things, if you're aware of these things, you could teach more efficiently and more effectively in the time you have, and you're not wasting so much time. So you may feel like you don't have much time, but there are ways to use your time so much better.
Makes total sense. Number 7, ignore or make light of the learner's concerns. I've never had a doctor make light of anything that either we've said or my wife has said. Ignore is a different thing. But what have you seen there?
I've seen both. One situation where you often see making light of is if a parent is asking about immunizations and is wondering whether or not they should get their child immunized. Sometimes the healthcare provider is so convinced immunizations are absolutely wonderful and perfect and everyone should have them that they don't actually hear what the concerns are that the parent is bringing up.
Yeah, I can see that. We've had some spirited family discussions because we have grandchildren now, and sometimes the spouses that your children marry don't have some of the same views that you do, and so there can become some pretty spirited discussions about that. And I can see how if I was in a situation like that and somebody said, "Oh, well, no, I'm not sure about this," that I could just blow right through that because it doesn't make any sense to me.
Right.
And so I could see very easily to the ability to ignore that. And that goes back to assessment and knowing who
Always.
you're talking to, doesn't it? It always goes back to that.
Yeah.
Number 8, teach when the problem isn't a lack of information. What do you mean there?
That happens more often than we realize. I mean, one example for sure is with obesity, which is a big issue coming up now a lot. A lot of people understand nutrition, and they understand what they should be eating and not be eating, and that they should be exercising more. But the issue is not education. The issue is how do they apply it to their lives.
Yeah, I totally agree with that. Now, there was another example that you gave in the book. It wasn't near this chapter. It was farther up in the book, but it was a story about, I think it was a young girl in a wheelchair, and she had problems with skin lesions. Tell
Yeah.
us that story, because I think it fits here.
I love that story because it was something that I experienced when I was a staff nurse early on. So I learned early on how important it was to listen to people and to ask questions. Basically, she was a adolescent with spina bifida, and she was readmitted frequently with osteomyelitis, just infections that started with skin lesions that went down to the bone, and she needed antibiotics in the hospital over and over again. And we would keep teaching her about skincare and her parents about skincare, and somehow they just kept coming back. And finally, after one admission, a nurse asked, "Why do you think this is happening? Why do you think they keep coming back?" And the girl knew the answer. She knew what the problem was. Basically, in their small house, apartment, her wheelchair did not fit through the doorways. So whenever she got home, she would have to jump off her wheelchair and crawl around the house to get around. So once we realized that, we were able to get home care to get her a smaller wheelchair that did fit through her doorways, and the skin problems stopped.
Isn't that amazing?
So it wasn't education.
Yeah, it wasn't education. In this case, it had everything to do with asking the right question or going farther than the typical questions and looking for environmental issues. That's interesting. But I found that story particularly interesting when I read it the first time in the book. It's like it just goes to show you that it's not all about the medicine. It's all about the relationship and the questions and asking that one more thing when you know whatever you're doing right now is not solving the problem. There's something else that's being missed.
And when there is an issue like that, it really does help to ask the patient, well, what do you think is going on, or what do you think the problem is?
Yeah.
They might have insights that you have no idea about.
Yeah, sure. Makes total sense. Well, this was good. I enjoyed this conversation. We covered the 8 most common patient education mistakes out there. And you can find these in Fran's book, and you can get Fran's book, No Time to Teach, wherever books are sold, at Amazon or Barnes & Noble. It's in both electronic form and paperback. And for hospitals out there, if you want to get some bulk purchases of these, you can get a 40% discount by visiting the publisher, Pritchett & Hull, and their web address is p-h.com. Fran, where can people get in touch with you?
I'm always on Twitter at No Time to Teach, and my website is www.notimetoteach.com.
And you publish a blog there frequently. I encourage people to go visit and make some comments. And then if they also prefer Facebook or Google Plus, you're also on those. And I think I saw you on Pinterest the other day too. Is that correct?
Yeah.
Yeah.
There aren't too many patient education pictures, but when there are, they're fun.
Yeah, I would agree. I've seen you there too. Well, thanks very much for your time today. I look forward to talking to you in the next couple of weeks. I want to let the folks know that the Patient Educators Update is brought to you by Synergy Broadcast Systems. My name is Chuck Jones. I forgot to tell you who I was, but not that that's important. But at Synergy Broadcast Systems, we make the medical media delivery system, which is a video-on-demand based patient education system. So you can provide 24/7 video education materials for your patients at a price that you might be surprised. It's much lower than you think. For more information, you can visit our website at synergybroadcast.com. Thanks, Fran. I'll talk to you soon.
Thanks, Chuck. Bye.
Hello and welcome to the Patient Educators Update. I'm Chuck Jones and I'm pleased to be joined by our regular guest, Fran London. Hi, Fran.
Hi, Chuck.
At the Patient Educators Update, Fran and I try to get up with each other a couple of times a month and talk about patient education issues. For those of you who may not know Fran, she is the patient education specialist at Phoenix